everyone. Welcome to Berry Chat with Dr. Sayat, where we have honest conversations about weight loss surgery, healing, and hope. I'm Dr. Alvin Sayat, a bariatric and foregut surgeon, and also a bariatric patient myself. This podcast is about understanding the science, the stories, and the people behind metabolic surgery. So settle in. Let's chat. Hi, everyone. Welcome to another episode of Berry Chat with Dr. Sad. It's my pleasure to have my program director, Dr. Fearing, here. She's going to be talking with us about your first surgical visit as part of your bariatric journey. Dr. Fearing, if you could go ahead, please introduce yourself and tell us how you came to be a bariatric surgeon and the work you do here at the clinic.
Sure. So I'm Dr. Nicole Fearing. Originally grew up in North Dakota and went to med school there, and then did my residency in Wichita and did my fellowship down in Houston. And originally I was in practice in Columbia, Missouri, and did all kinds of minimally invasive and bariatric surgery, and then moved my practice to Kansas City. And when I did, I moved it purely to bariatric surgery. And I think bariatric surgery is a way to make a huge difference in people's lives and continue to see them. I don't have to say goodbye to you versus, as you know, if I did an appendectomy on you, I would take your appendix out and see you in follow-up in the office and never see you again. And so this way I can have a relationship with a patient and I can see them for years to come and not lose touch with them, which I really enjoy.
Is that what led you to bariatric surgery, or what sparked your interest to pursue that field?
That really was it. It was really being able to help someone make that immense change in their life and continue to be part of that. And the medicine behind obesity is fascinating. I love it. And the surgeries are great. And it just kind of wraps everything that I love all together. So did I love doing other kinds of surgeries too? Yes. Get the same long-term relationship with patients that I do now. And I really, really like that.
And then before we dive into, that first visit with you, it's something that comes up and I wanted your take on it is, why is it that bariatric surgery has changed its kind of representation of bariatric and metabolic surgery? Why the name change, and where did that come from?
Well, I think it's been a long time coming. And I think when you have gone through the years of this, it's changed in our perception of obesity as a disease and what it does to the body. And when people finally started looking at it as a true disease, that's when the metabolic part really came in. And it's just not a disease that we fix by surgery. There's just so much more that goes into it. And so I think encompassing it more with bariatric and metabolic surgery, we're not affecting just how much somebody eats and how much they absorb. We're affecting their hormones. We're affecting their gut health, where there's so much more that is being affected, way more than we even really understand at this point. Know that it just encompasses a bigger, wider field.
So going to that first visit with you, where are the patients coming from? Are they referrals? Can patients come and find you on their own? How are the patients coming to see you in the clinic?
Patients come from a variety of different ways. And probably the biggest way that people come in to be seen is by word of mouth. They have a friend or a family member that had surgery, and they're like, oh, well, go see this doctor. I really like them. And so that's where I get a lot of patients. People as well look you up on the internet, right? And you may start thinking about weight loss surgery and kind of look up, and you can look up and see who all the doctors are in your area, but then you start looking up their reviews, and once you start reviewing people, then you kind of get an idea of the lay of the land, how people are. And then people make a lot of decisions from that. And then obviously, your family doctors, your primary care physicians, your other docs that you see may refer you over to be seen. So there's a lot of different ways. And there's also insurance companies. Many insurance companies will tell people who they have to see, depending on contracts and that kind of thing. But probably the biggest way is just word of mouth.
And then in that initial visit, I've done clinic with you. You've got the pre-op visit, the sheet that you want patients to fill out. What
can they expect from the conversation you're going to have with them? And what are you looking for in that sheet and looking for even before you walk into the room to talk to them?
So when I wrote the sheets, the intake sheets for people, and I think I probably told you this before, the thing that I look at the most is what are you expecting to get out of the visit? And I want to make sure when I'm going in there, as long as you filled out the question, that I'm meeting your expectations, and that if you think, I'm coming in and you're going to get surgery that day, then I have to kind of tell you how expectations are going to roll. And you're not going to have surgery that day, and it takes a little bit of workup. So that's my most important question that's on there. On all the paperwork that people fill out, there's a lot of the questions that are on there. So I get a feel of what their health problems are, kind of what their eating habits and exercise habits are, what they've tried before. So I can really get a lay of the land and really know before I go in there. So I'm not asking all the same questions, but maybe I'm asking questions that can get us to a better realization of what the best procedure might be for them.
Okay. And then speaking of, the procedure, or before we talk about the procedures, who is a good candidate for bariatric surgery? Who, when you walk in, say, yes, like you have these options versus no, not really. How do we make that decision?
Well, there's a couple different ways to look at it. If a person's going to be a good candidate for surgery, they have to be ready in their heart to have surgery. And so there are people that come in because their doctor told them they have to, or they said that they've got to lose 100 pounds before they'll do a joint surgery, but they're not ready, And so I can talk to them about surgery and I'll give them all the information. But I always tell them, if you're not ready in your heart, don't do it. Because if you have a complication or, something doesn't happen the way you want, that's not a good procedure for you. It's better to just wait and be ready. And then the other things that we look at are, what are your current health problems? Do you have high blood pressure? Do you have signs of sleep apnea? Do you have reflux? Do you have difficulty swallowing? All kinds of little things that may affect the choice of procedure. And, just because you have some reflux doesn't mean you can't have a gastric sleeve. But if you have horrible reflux, we're going to talk about how horrible reflux can be made more horrible by a gastric sleeve. And then we really talk about expectations. And if you're somebody that loves to take ibuprofen a lot all the time, having a gastric bypass may not be your procedure because you can never take ibuprofen again. And so we've really got to go through all of that really well first as well. And then I really like to go by eating patterns and see what are your eating patterns and what are you willing to change. If you're somebody that drinks a lot of soda every day, are you willing to give that up and get rid of that? Are you somebody who likes to eat in bed? And I always tell people Dr. Fearing's rules of eating in bed are bed is for sex and sleep. That's it, not for eating. And so we've got to take the eating, back to the table and not do mindless eating. So a lot of the questions I ask are kind of ways to talk about how can we change our habits. And so we spend a lot of time on that as well, too.
Is there times that there are certain goals you want them to meet before you see them again to discuss the procedures, or you'll still discuss the procedures with them and just to give them all their options?
Now, I like to discuss procedures with them right then. Patients who come to see us, they usually watch videos about the different surgeries. And if you're starting to think about surgery, you've probably been all over YouTube or watched My 600-Pound Life or, something, and you have some idea about it. And I like to talk about the procedures. We know that first visit is overwhelming to people. It's just scary enough just to walk in the door and start talking about weight. That's scary. And then we're talking about all this stuff and then going through all the procedures. So it can be overwhelming to people. I like to just keep going over it again and again and again. And then if they don't know, I just tell them, you don't have to decide about any of them today. You just let it sink in and go home, talk with your family about it, and we can talk about it more later.
And then what are the different procedures that you discuss with the patients? I know, everyone's heard about the sleeve, the
Yep.
most popular bariatric surgery, but what other, besides that, what other options do they have?
So we talk about all of them. And so there's the gastric sleeve, there's the traditional gastric bypass. Those are the two most popular surgeries for weight loss. Gastric bypass has been done since the 1960s in various forms. There's the duodenal switch, and we at this practice do the one anastomosis duodenal switch, meaning there's just one connection up to the stomach. There is the what we call the one anastomosis gastric bypass, which we do in the office. And those are the four main surgeries. We don't do lap band anymore, but we also service lap bands. So if there's a patient that has a lap band in that needs to be seen for fills or unfills, we'll do them, but we just don't really do lap bands anymore. And then there are endoscopic options for weight loss. So there's the gastric balloon, which is done. It used to be you could only do it have it in for 6 months. Now it's for a year, and then it has to be removed. There's the endoscopic sleeve gastroplasty. Those are the two main ones that we do. And then we also do revisions. So there's a lot of people that come to see us who've had weight loss surgery elsewhere. And maybe they haven't got as much weight off as they would like, or they haven't been as successful as they would like, or have a complication. Then we'll talk to them about revisional surgery. And revisional surgery is one of the fastest growing surgeries in the United States.
And just for the viewers, does it mean that, if they have a sleeve, you're going to give them a tighter sleeve, or is it that we're switching them to something else?
So we don't typically re-sleeve people. That's what it's called. When you re-sleeve a person, we usually switch them to a different procedure. So if somebody has a gastric sleeve and they haven't gotten enough weight off, we may consider going to the one anastomosis duodenal switch, or the SADI procedure. If they have severe reflux after a gastric sleeve, we may consider doing a gastric bypass, or what they call the mini gastric bypass, or the one anastomosis gastric bypass. But that entails a lot of workup in between there to think about that.
And then for all these different procedures, is there kind of a branch point for you to say, this patient is better suited for the sleeve, better suited for the bypass, the SADI? What is your decision making for that, and how you counsel the patients?
So it depends on what patients' BMIs are. So if a person is young, any age really, and they have a really high BMI, then we're going to steer them towards a procedure that's going to get as much weight off as possible. If they're not ready for that and they only want a sleeve and that's all that'll be okay, but we have to talk to them about there are other options they may want to consider in the future. If a person has severe reflux, then that may branch off and affect things. If a person wants to get pregnant, and real soon afterwards, that may affect that conversation. Or I may tell them, get pregnant first, have your baby, and then do it. It really, really depends on that whole workup and kind of where they are and things.
And then, so, let's say, somebody chooses that surgery. What happens afterwards? When do you see them next?
When you're talking about the decision tree, there are patients that if they're deciding, say, between a sleeve and a gastric bypass, there are people that don't like the idea of a portion of their stomach forever being removed. That creeps them out. And so when you have a gastric bypass, all your parts are still there. They're just rearranged. So they like the idea that all their intestine is still there. Then there's the other side of it, that there are patients that don't like the idea of their intestine being rerouted, and they like the normal continuity being intact, so they don't mind having a gastric sleeve. So I should have said that. So there can be two camps. And so if I have a patient that's really on the fence trying to decide, I explain that kind of two camp theory that I have. And sometimes that's helpful to them.
And actually, that spurred on something I wanted to back up and talk more about. When I was first learning about these procedures, they were talked about as like restrictive and malabsorptive. Why have we kind of ventured away from that? And why is it not as easy as just saying, oh, we're just restricting how many calories that you're eating?
Because we know with the gastric sleeve, there's so much of a hormonal gut effect to it. And you may have talked about this before, but when you remove the fundus of the stomach, we affect a lot of the cells that affect one of the hormones, ghrelin, which is one of the hunger hormones. But we also know there's an effect of how fast things go through the duodenum as well too. And there's so many that affect obesity. We still are at the tip of the iceberg, really understanding it. But we know that there's much more of a metabolic effect with the surgeries than we even really understand.
What kind of weight loss can patients expect with these different surgeries?
So I typically quote, and you can have people all around the country will quote you different things, but I typically quote with a gastric sleeve about 50 to 60% excess weight loss with gastric bypass, 60 to 70, one anastomosis, gastric bypass, 70, 80, and 80 to 90 with duodenal switch. And there's variability in all of that. And so, but that's what I typically quote. Only 6% of people in the nation lose 100% of their excess weight, meaning if you're 100 pounds overweight, you lose all 100 pounds. And I like to tell patients that too. So expectations are there. A lot of people say, well, I want to get down to 154 pounds. Well, I can't control that. Your body is going to lose a percentage of that weight. And then the extra comes from exercise and using it as that tool and building muscle mass and getting good sleep and good health. And you may never get to that point. That just depends. And I don't want to get too wide in the weeds, but there's also something that's called a set point. And there's a belief that we all have a body set point that our body is trying to get back to. So as we lose weight, there's some thought that our body is trying to get back to that, whatever the body's set point is. And it's hard to change a set point. I tell people the best way to change your set point is to get good sleep at night, work on good gut health and good fiber in your diet, and then build muscle mass.
And then what risks can patients expect? Like, what do you count? We were talking about all the benefits and, obesity affects not just your weight, but all the comorbidities, high blood pressure, diabetes, obesity-related cancers, sleep apnea, all these things get reversed and cured, for lack of a better word. But what kind of risk can patients expect with all these different surgeries?
Sure. So every surgery has risks. And so I tell people there's risks of bleeding and infection, same as any cuts you get on your skin. There's risks that we can't do it laparoscopically and have to convert to an open procedure, and that's very rare. But there's risks of bleeding along the surgery inside itself. There's risk of what's called a leak, where food or fluid can leak through the staple lines. There's risk of strictures or narrowing along the line of the surgery. There's risk of ulcers with gastric bypass surgery, and that's why we tell people that you can never smoke with them or never use anti-inflammatories. With gastric sleeve, the big thing we talk about is reflux and the risk of reflux, and you can get quotes from people all over the board, but I tell people 15 to 40% risk of reflux afterwards, to the point where some people have to be on antacids all the time, and about 4% of people have to convert to a different procedure to deal with the reflux. Nausea and vomiting, those are the big things. And then vitamin deficiencies. So when people have weight loss surgery, I tell them that they commit to several things. They commit to follow-up. They commit to never smoking again in their life, anything, marijuana, being cigars. They commit to taking their vitamins the rest of their life. And it's so incredibly important to always take their vitamins.
Speaking of the vitamins, we had Kyle on the show earlier, and I just wanted to reiterate, why do we always harp on bariatric multivitamins, not just the men's once a day or the Centrum, et cetera? Because patients will tell us, oh, I take a vitamin.
So we actually researched this. One of our dietitians years ago went through and really researched this. And it takes about 16 over-the-counter vitamins to equal one bariatric vitamin. And so it's actually cheaper to take bariatric vitamins than it is to take all the over-the-counter. Bariatric vitamins are formulated for absorption for bariatric surgery, and they're formulated to help you absorb the things that you may miss when your gut is being rerouted. And so it's just so incredibly important, as you know, and the deficiencies that can occur can be life-altering. And so it's really, really important just to take your vitamins. And, some people don't like taking pills or don't like to take them, but it's really, really so important. I just say if you have surgery, you commit to taking vitamins, and you And the other thing is not taking. So you don't take NSAIDs, you don't smoke, and you always take your vitamins. Those are the three things.
And then I know, it comes up in that initial visit, the endoscopy. Can you tell people what is an endoscopy and which patients are we doing that for before their surgery?
So it is not routine for every bariatric surgeon in the country to do an endoscopy on their patient, and that is doing a type of scope. And we usually do it down the mouth to look at the esophagus, the food tube, the stomach, and the first part of the small intestine. So if we have a patient who's got heartburn or reflux or kind of abnormal swallowing or sticking when they swallow, we like to scope them to make sure that they don't have an abnormality that might need to be treated prior to surgery or during surgery, so that we kind of set up expectations beforehand. And so there's lots of times that we find things that we didn't expect to find. I found a cancer in a patient the other day, and had I not scoped her, she wouldn't have had it found until much later. So thank goodness we did. And it really just helps us get a good sense of choosing the right procedure for the patient, and are we setting up the appropriate expectations for everybody?
Absolutely. And then the other thing, patients will come and ask us, is bariatric surgery safe? Like, there's so many horror stories about complications and things like that. What's the discussion you have with patients regarding that?
So years ago in bariatric surgery, years ago when I started bariatric surgery, was a long time ago. Before that, it had a bad name. It was considered the Wild West. There were people doing kind of made up surgeries or parts of gastric bypasses and stuff. And so it just wasn't regulated. And then our national organization really put together accredited centers and standardized expectations. And so over the last 20, 25 years, it's really been standardized, and the outcomes have improved and the risk has gone down. And so now, if you look at the risk numbers for weight loss surgery, if we look at a gastric sleeve, the risk of like a major complication such as death is about 1 in 1,500 to 1 in 1,800, approaching that of taking your appendix out. And the risk of a gastric bypass is about 1 in 1,100 to 1 in 1,200, which is approaching gallbladder surgery. So these are, appendix, gallbladders are mainstays of general surgery. And, we don't think of them as really that risky. And so gastric bypass and sleeve, they really have approached that now. And it's really due to the strong work of the people who've gone before and really standardized it, looked at outcomes, pushed people to have good outcomes.
And you mentioned that, and it dovetails into my next question, which is bariatric centers of excellence. What are those, and why should patients try to find surgeons who are working out of those kinds of centers of excellence?
So what they really are is called accredited centers. Through the American College of Surgeons, they are what's called MBSA QIP centers, and we're accredited. And we've met certain guidelines through the national organizations that we have agreed to educate our staff and our nursing staff and our doctors to a certain level, that people are trained to look for complications, that they're trained in patient safety, and they're also trained on being sensitive to obesity and not being bullies about it or rude about it, so they're all trained to a certain level. They're all trained to certain outcomes. And so we become accredited centers. And then each insurance company then calls them centers of excellence. So like our program is a center of excellence with every insurance company. And they go back and they look at the accredited centers and they make sure people have met the goals of the accreditation. And then every 3 years, we go through a reaccreditation. We make sure that we're meeting the expected outcomes. And twice a year, each program, like our program, twice a year, we go through our outcomes, and then we do performance improvement projects to see what do we need to do better. We have met expectations on our outcomes consistently for quite a while. But even then, we say, even though we're meeting expectations, what do we do for the little ones that we might have? If there's a blip, we got to figure out, is there something we can do better? And we keep working on it to be better.
And then another question patients will ask is, what's the downtime after surgery? What is your technique for approaching bariatric surgery, and what are the techniques that are out there?
For downtime?
In terms of, like, are we doing open surgery?
Oh, no. We're not doing open surgery. So I do all my surgeries what's called laparoscopically, and then my partner does them robotically. And robotically is a type of laparoscopic surgery. And so when you do things laparoscopically and robotically, it decreases the downtime because it used to be years ago, we do huge incisions on people. They'd be in the hospital for days and they would be off for a long time. Now, most people are off a week, some people 2 weeks. And I really tell people it takes about a month before you feel like you have your energy back. But, if you have a very physical job, then you may want to take a month off. If you're sitting at a desk most of the day or you're working from home, you might just need to take a week off. Just really depends.
So let's say that, the patient's gone through they've met you, they met their clearances, they arrive 5:30 in the morning at the hospital. What can they expect that day?
So they can expect they come in and they check in and they get brought back to pre-op holding and they get to meet, for us, they meet their nurses and they kind of talk about what's going on. They usually have to go pee in a cup somewhere to make sure if it's a female of childbearing age, we make sure they're not pregnant. And then they change into their gown and then they get a line in, they get an IV of some kind in and get blood tested, and then they'll meet with anesthesia. For our patients, we use what's called enhanced recovery protocol. So everybody has a drink that they take 4 hours before they come in. And then there's a concoction that they drink, excuse me, to help decrease pain and nausea postoperatively. They'll meet with the surgeon, they'll meet with our fellows and residents, and then the crew that's ready to take them back will take them back to the operating room. Oftentimes they'll get a little sleepy medicine so they don't feel nervous going back to the operating room. We try to give them some warm blankets so it's not so cold when they get to the OR, and then they'll go off to sleep.
And then how long are these surgeries generally, and how long can the patient expect to stay in the hospital?
It depends on the surgery. Surgery can be anywhere from an hour, sometimes 4 or 5 hours, depending on if it's a revisional surgery. And then when they go back to the OR, part of our enhanced recovery protocols, they often get a block of their abdomen as well to help decrease pain. So they may, be back there for, the family feels like it's a lot longer than our actual operative time, right? Because they're going back, they're going off to sleep, they're getting their tap block, we're operating. Then there's time to wake up and time to go to the recovery room.
Do patients typically stay 1 night, 2 nights? Like what does that recovery period look like? And what are your goals for them before you're okay with them leaving the hospital?
Most patients just stay overnight. Some people stay a couple days. But the goals, when we talk about discharge criteria, we want people walking the halls 3 or 4 times, 5 or 6 times a day. They're getting all their fluid in, and that means, 4 to 6 ounces an hour, and that their pain is controlled and that they're not nauseated or they're not vomiting. So we really want to see them meeting all those goals. And if they are, then they're good to go. And it may be the next day. There are some programs, not our program, but there are some programs where some people go home the same day. And I don't really feel comfortable with that yet, but maybe one day I will.
I did see a recent article that came out that said it was safe. However, the rates of readmission before dehydration are higher for bypass and sleeve, that they're discharging the same day. Yeah. So we were talking about the post-op care. So once the patient leaves, what's the post-op visits look like?
So our post-op visits, we like to see people a week after surgery, a month after surgery, 3, 6, 9 months a year, 18 months and once a year. And the way that we have it set up, we kind of try to toggle back and forth with the nurse practitioners. There's a lot of programs that don't see patients after the first 90 days. Or they may have the patients see their primaries back, or an endocrinologist, or a medical bariatrician. So every program does it different. And I won't say there's a definite right or wrong way to do it. But I think the most important thing is continuing to follow up. And the reason that is because obesity is a disease. I would say obesity is a disease we're all on the trajectory from that is on an upslope. And surgery is the strongest thing to knock the slope down. It's not 100%, but it's the strongest thing that we have. But because it's ongoing, we have to continue to see people to affect the other things that affect obesity, to make sure that sleep is going okay, that your gut health is good, that you're building muscle mass, that your stress is staying down, that you haven't added on a bunch of medicines that cause weight gain. And then if any of those things are occurring, then we're there to try to help you navigate that and try to decrease the effects of some of those things as well too.
So I wanted to circle back, I guess, to a conversation that can come up in the initial visit. What what do you tell the patients that say that they feel that bariatric surgery is a cop out or it's cosmetic surgery, or we had a patient the other day that was worried that we were going to scold them that, you just didn't work out enough or eat right. How do you navigate those conversations?
Well, I think anyone that's come to the office has tried to lose weight a gazillion different times and it hasn't worked, or they would have not been in the office. And I think part of that it happens when you feel that way is shame. And shame can be a barrier for moving forward. And so I think a lot of people have to work on dealing with shame. And I always tell them, knock the shame monkey off their shoulder. It's you can't move forward if you build the shame wall up. And so I can go on a whole tangent about that. But if losing weight was easy, I wouldn't have a job. And so again, it goes back to all the things that cause weight gain are more than how much you eat and how much you exercise. It's so much more than that. And so it's not the easy way out. Many of my patients, as you know, and you can say, will say, this is hard. It's changing my lifestyle. It's changing how I think. It's work. It's not the easy way out. Would they do it again? 100 times they would do it again. But it's work. And I ask people that all the time. I ask people all the time, and when we do our patient panels, what would they tell their old self? If they're at their 1-year visit, what would they tell their self that's a year, 2 years out, before that? What would they say? And they always say, I wish I'd done it sooner. Do it.
Yeah.
Do it sooner.
I could not agree more. That was exactly when people asked me about it, because I was a patient myself. I had the gastric sleeve. The way that it fundamentally changed my life, that was the first thing I said, was like, I wish I had done this sooner. I can't believe, because I was also, like what you said, the shame monkey of cop out, et cetera, plus cultural pressures as well. That's a different episode, different conversation on its own. But with all the benefits that came with it, it was just kind of a no-brainer of like this. I can't believe this is an option, that this exists for people, because it just really is life. It's a life-changing tool.
It really is. And it's the best life-changing tool we have. And we have people, just like you're a professional. I have people who are lawyers and psychologists and professionals, all kinds of people. We all know how we should eat and what we should do. But the thing is that it's hard. And eating is something we need to do to live. It's part of our culture. And when we start shaming ourselves for how we live and how we act, it just makes us get deeper into the rut. It's hard to get out of it. And so what I tell people is you got to go, yeah, it happened, and I got to move on. And it's hard sometimes to move on, but if you're surrounding yourselves with people who are going to help you get there, it's going to help you that much more. I liken it to trauma surgery. And when somebody gets shot in the chest and you have to operate them, I don't go to the operating room. I used to do this. Don't do this anymore. But you don't go to the operating room by yourself, right? You go there with all these people. You got your anesthesiologist, your perfusionist. You pray that the cardiothoracic surgeon is going to come in at some time, and all the nursing staff. And you load the boat with all these people that are going to help you save a life. Why not do that the same when we're dealing with the number one health problem in the country, right? So as a patient, you're not just going in with me as your surgeon. You're going in with the dietitian and our coordinator and our nursing staff who's been trained for this. And so many things, our support group, there's just so much there to help you move the ball forward.
I was using the surgical oncology analogy of, we've got the med-onc, the rad-onc, the surg-onc, all the chemos, et cetera. Now, and that's a separate episode talking about the GLP-1s and surgery. I like, because I came from a big trauma program, so I definitely like that analogy. That's a really good one.
Yeah. Load the boat.
Load the boat. Absolutely. The other thing I wanted to talk about was as part of the visits, the labs. Why do we check those labs in these patients, and what can patients expect in terms of like their lab work?
So I think it's really important to check lab work before we ever operate on patients, because most people are deficient in a lot of different things. Just because we may eat a lot doesn't mean that we are nutritionally repleted. And so most Americans are deficient in vitamin D. We know that. But there are other vitamins that can be deficient. And so we want to get things corrected as much before surgery. A lot of our patients are iron deficient before we ever operate, and they may be anemic. And so we don't want to operate on someone who's anemic before surgery. We want to make sure that they're as optimized as possible beforehand. And then after surgery, we want to continue to check to make sure there aren't any deficiencies that are going to affect you. And so we'll check lab work for duodenal switch. We do it every 3 months for the first year. For a gastric bypass, we do it at 6 months and on a yearly basis
Seeing the patients afterwards
for the rest of their
for
lives.
the rest of their life. I mean, it's very unique with this practice. And we had an episode with Dana about insurance and, you know, the indications for bariatrics set forth by the ASMBS. But however, there's the statistic that we talk about that only 1% of the people who qualify for bariatric surgery get this surgery. Why that huge disconnect between who qualifies and who's actually getting the surgery? But in your experience, what do you think?
So there's a number of reasons, right? Shame, right? People think it's the easy way out. There's doctors that'll tell people, put the fork down, back away from the table. It drives me crazy when people say that because it's not, there's no science in that, right? So that shame, I think, is a huge reason for it. I also think it's just education. And, you know, we've got to educate more that this is the biggest tool. We have the medications that are out there. We have companies who have a lot of money, billions and billions of dollars to spend on marketing, but we don't market the best tool that's out there, which I think is a shame. And we hit less than 1% of the population who could really benefit from it. So it's education, it's getting rid of the idea that it's the easy way out, and just really getting people out there to tell their stories. There still are people who have had weight loss surgeries that don't want anyone to know that they've had weight loss surgery. Like, it's embarrassing. Like, well, if you have cancer, it's not shameful to tell people you got cancer. But for some reason, people don't want to tell people that they've had weight loss surgery. And I think it's very brave to go and have surgery and work on this and to make that huge of a change in your life.
And as we're wrapping up, I wanted to ask, where do you think the future is? Where is bariatric surgery going? And how can we expand it since it is our strongest tool in the fight against obesity?
I think bariatric surgery is in evolution. I think that it will still be here. I think that what we're seeing now is that we need to treat, you brought up the oncology analogy, but we need to treat obesity kind of like cancer, where surgery is not the only tool. There are many things that have to come in it to fight obesity. We know that if we use surgery and some of the medications together, we can augment that weight loss even further. We know that if we work on building muscle mass, that will help. There's so much science on gut health. You've heard me say it before, but the gut microbiome is really going to change obesity medicine. I believe that 100%. And so I think in the next 20 years, as we learn more about the gut microbiome, that is going to change how we deal with obesity as well. I think obesity continues to have to be treated what I call a kind of a wheel and spoke method, where we got to hit it from multiple different ways as well. And we also have to hit it from our food supply and really look at, that's another thing I could go on and really look at, the fructose in our food, our processed food, and really trying to get rid of highly processed food. And really get a lot of education for people on that and really bring in real foods to communities that don't have the access to it.
No.
So that should be a whole nother podcast. We can do that.
Absolutely. Going off of what you said, I think, because we had that, the fellow project on the pathophysiology of obesity, I think one of the takeaways I had from that talk was how just doing the surgery drastically changes your gut microbiome. I thought that was fascinating on its own, and that you shift towards a healthier homeostasis than you had before. And we're not, introducing a new medication or like a fecal transplant that you would think of like you're changing the bacteria. It's just rerouting things and how drastic that has an effect. So definitely I agree with you. Gut microbiome and just all the research.
It's super cool. Yeah.
Very cool.
Yeah.
Well, thank you so much, Dr.
Thanks
Schramm.
for having me.
I always like to end every episode with, if there's one thing you want the folks to take away from today's talk, what would that be? And, or what would you want them to know?
I'm going to sound like a broken record, but it is not the easy way out. And so, if this is something that you're thinking about, don't shame yourself into thinking that you just need to eat less and move more. It's not the easy way out. Find someone who's had surgery, continue to listen to your podcast, look at some of the support groups and really realize that this can be life altering and you can live a healthier life by doing this.
Absolutely. Agree. Well, thank you again. And
Thanks.
thanks for everyone for tuning in to another episode. We'll see you next time.
Thank you for listening to Barry Chat with Dr. Sehat, where we have real conversations about surgery, healing, and hope. If you found this episode helpful, please take a moment to like, share, and leave a review wherever you listen. It really helps others find the show and join the conversation. If you have questions or topics you'd like me to cover, you can email me directly at drajsehat@gmail.com. And if you'd like to stay connected, follow the links in my link tree, right in the podcast title, for my social media pages, updates, and educational content. I'm Dr. AJ Sehat, and this is Barry Chat, real talk about surgery, healing, and hope. The information in this podcast is for educational purposes only and should not be taken as medical advice. Everyone's health situation is unique, and decisions about bariatric or metabolic surgery should always be made in consultation with your own physician or healthcare team.